Okay, I think we'll go ahead and get started. Welcome everybody to the webinar today. Our topic today is trauma-informed care, and we have a really great presentation from Dr. Monica Weldon from RI International. The CARE TA Center, for those of you that don't know, are really charged with providing training, technical assistance, and a host of other services intended to help agencies, counties throughout the state of California improve behavioral health coordination, improve the crisis response to care. And the CARE Technical Assistance Center is comprised of 5 key agencies. Those agencies are listed here: the Center for Applied Research Solutions, C4 Innovations, California Alliance of Child and Family Services, Impact Justice, and ourselves, RI International. Before I introduce Monica, I will just say my name's Sue Ann O'Brien. I'm the Vice President of Crisis Services Integration with RI International. We help people across the country in implementing crisis systems, everything from 988, mobile crisis, facility-based crisis work. We do a lot of training around peer support, and we have a lot of expertise in-house. We are also a direct service provider, like many of you are. We have outpatient services, crisis-based facility services, and a host of other things that we do provide across the country in 10 states across the country. We are a nonprofit, and we have a lot of subject matter experts on our staff. And Dr. Monica Weldon is one of those folks. I've known Dr. Weldon for I don't know how many years now, many, many, many years. She has a doctorate in behavioral health, and the focus of that degree has really been on, and many of you have heard about, the integration of behavioral health and primary care. And this is a very unique degree. It's one of the first in the country that's actually focused on helping clinicians, behavioral health clinicians, become trained in a focus on primary care with a strong emphasis on physical health. And that was right up her alley. She has always had a unique interest in the intersection between a person's behavioral health and their physical health. And so she's got a lot of experience and a personal passion around trauma-informed care as well. So I'd like to just introduce Dr. Monica Weldon to you, who will be presenting our slides today. The learning objectives, things you can hope to learn from today's webinar. You should be able to define the 3 E's of trauma, identify the 4 key elements of a trauma-informed approach, be able to describe the relationship between adverse child events, which is called the ACEs scale. Many of you might have heard of that already. And then be able to name 1 strategy for implementing a trauma-informed approach in your workplace. And that's what we're really hoping, is that something that you learned today is new to you. And it's also something that you can take back and incorporate into your work, into your practice, into your respective agencies. We're going to start out with a little bit of a polling question. I would love to hear from everybody here. If you would drop your answer in the chat. Do you think your organization is trauma-informed? If it is, give us a great example of how or what your agency has done that you think makes it trauma-informed. So we have some people saying yes, they do believe their organization's trauma-informed. We have some saying nope. Violetta says a bit. Flexible, open access, for example, that would be one way to be trauma-informed for sure. Parts are not. Somebody said welcoming warm lobby, open space, welcoming people, starting to train staff on trauma-informed care. Those are all great examples. Okay, a lot of not sure or room for improvement or in development. Training staff again on recognizing trauma. These are all really great comments. And hopefully today you'll hear a little bit more from Dr. Weldon about how what some other very concrete things you might do in your own organization and in your own practice, and take those back to your agency. So without further ado, I will hand it over to Dr. Weldon to jump into the trauma-informed care presentation. Dr. Weldon, thank you for being here today.
Thank you so much, Sue Ann. Appreciate that. And thank you everyone for being here. Thank you for all of your answers to the question. It sounds like a lot of you already know a lot about trauma-informed care, and some of you are already doing it and some of you are working on it. And I would say all of us are who are working on trauma-informed care, there's always room for improvement. It's an ongoing process, right? So I'm just going to start with a little bit of just a definition for those of you who might be new to learning about this concept. So, what is it? What is trauma-informed care? So SAMHSA kind of describes this as just a universal framework for an organizational structure and treatment that involves understanding, recognizing, and responding to the effects of all kinds of trauma. So what it's not a prescriptive model. It's not a manualized practice. It really is a paradigm or a philosophy, kind of underpins the entire philosophy of how we approach people, how we approach the services that we provide, and our workforce. And so it emphasizes a physical, psychological, and emotional safety, both for the people that we serve and for providers. So looking at who we were providing services to, ourselves, one another, the agencies that we collaborate with, everyone in the system. Really looking at helping survivors to rebuild a sense of control and empowerment. So first we have to understand a little bit about what trauma is. Right? What is trauma? You want to know, there's lots of different definitions, and people think about it in lots of different ways. So kind of have a shared understanding of what is trauma. So looking at SAMHSA's definition, looking at it from the 3 E's perspective, it's not just an event. That's one piece. One piece is the event or the thing that happens. It could be exposure to an event or a series of events. It could be multiple things that kind of happen in a row that threatens your well-being, threatens either the well-being of a person or a group of people. And then the experience of that event. How do we emotionally experience that event? Do we experience it with intense fear, a sense of horror, a sense of helplessness, feeling a loss of control? And does that experience have an effect of shaking the basic foundation of our belief about our safety, our ability to trust one another, the people that are supposed to care for us, ourselves, the world in general? Are we able to, feel like we can predict what's coming next? Do we understand, does it shake just our foundation of how we interact with the world? Sort of those 3 E's, the event, the experience, and the effect, those 3 things together is what creates that trauma. So now we know what trauma-informed care is and what trauma is. What does a trauma-informed approach look like? You think about a trauma-informed approach, we think about it from the 4 R's. So there's realizing. One is realizing the prevalence of trauma, that trauma is incredibly widespread, much more so than we used to think decades ago, right? Recognizing how trauma affects people, individuals, but also programs, organizations, systems, including our own own workforce, our own behavioral health workforce, health care providers, our own systems. And then responding. How do we take that knowledge? Now we know how widespread it is. We recognize the effect. How do we respond? How do we put that knowledge into practice? And then resisting or avoiding re-traumatization in the care setting. How do we avoid that sanctuary trauma or re-traumatizing people who are coming for help in the places that they're expecting healing or service or recovery? How do we avoid re-traumatizing or traumatizing them again in the places people are coming to seek care? So we're going to go over each one of these in more depth. And again, if you have any questions or thoughts as we're going, feel free to just put those in the chat. So one is just realizing the prevalence. What do you guys think? How prevalent do you think trauma is? The people that you've seen, the people you experienced, do you think it's some people, most people, huge? Yeah, a lot of people, right? So just realizing how widespread trauma is in our culture is an important factor to be able to understand how to identify that and how to respond to that. Most people, yeah, especially people who are coming in for care, right? So, there's different statistics we can look at. Some statistics that we see, so over 50% of women and 60% of men report at least one traumatic event. Other places you look, those numbers are higher. So it depends on, what group of people that you're looking at. In 2020, about 13 million Americans reported were living with PTSD. That's a lot of people. Looks like, women tend to be more likely to develop PTSD than men. One of the reasons for that could be that sexual assault tends to be the number one cause of PTSD, and sexual assault, although not strictly affecting women, tends to affect women in larger numbers. Veterans are more likely to develop PTSD than civilians, and veterans who experience war more likely to experience PTSD than veterans who do not. So, different circumstances and different situations, different populations of people have different experiences with these types of diagnoses. And we're looking at people who do have these kinds of diagnoses. More than 80% of those with PTSD also are experiencing another psychiatric disorder. So there's a high level of comorbidity. People are being impacted by multiple things at one time. And a third of those with PTSD, these things are persistent. So this lasts year after year after year. Can imagine how much that, and you've seen how much that impacts people's quality of life, their functioning, their ability to, work and have relationships, and all of those things that help to create a meaningful and quality life. I want to talk a little bit about children. I'm not sure how many of you work with children, but what we do know is a lot of trauma happens during childhood. There was a proposal for a diagnosis specific to children that was proposed to be added to the DSM-5. It didn't make it into the DSM-5, but I still think it's an interesting concept. We know that at least 2/3 of children report at least one traumatic event by the age of 16. 1 in 7 children have experienced neglect or abuse in the past year. This is from this year, 2023, from SAMHSA. 54% of U.S. families being affected by some type of disaster, and I suspect with climate change that's going to increase over time. So looking at, how does trauma affect children during childhood? We're going to talk about how trauma during childhood affects us as adults. But how does trauma affect children when they're children? That shaking that trust in the world, thinking the world's become a bad place, not being able to trust your caregivers or adults or others, They may begin to attribute hostile intentions to something that's just really, neutral or even positive. Not really believing that there's much of a future for them. Um, you know, they may be re-victimized later on in adult life. We're going to talk about that a little bit later. They may begin to reenact the trauma that's happened to them with other people, other children, maybe even younger children, and putting those children in that victim role as they are reenacting that trauma that occurred with them. Having difficulty with empathy, not being able to kind of put themselves in someone else's point of view, and having difficulty with relationships and school, and all kinds of different ways that can impact children. So just understanding how that comes out and how that might be misunderstood, I think is important. Looking at like, are we maybe misdiagnosing some things that maybe are really trauma? It's an interesting question. Just more about recognizing the impact. No one is immune, right? Trauma can impact every single one of us at any given time. SAMHSA talks about this as, having no boundaries. It can affect us regardless of our age, our gender, our socioeconomic status, our race or ethnicity, sexual orientation. It's a common experience, especially common for people who have those comorbidities, who already have a mental health or substance use disorder. I suspect that a lot of times those mental health or substance use disorders are symptoms of trauma. So it's kind of a chicken and egg situation, right? Which one came first? They're definitely playing into one another and hard to separate out. We need to address trauma. It's increasingly important that we effectively address this as behavioral health and an integrated part of the healing and recovery process. We can't separate out like, oh, trauma's over here and we're going to address these other things over here. We have to start looking at trauma and address trauma as part of healthcare. I would say not just behavioral health care, but all healthcare. Other ways that affects us, huge ways, right? First of all, it literally changes the brain. So some of you may already know this, right? That trauma physically changes the brain, and we have studies now that show this. They're functional MRIs and other scans and things where they're showing what the brain looks like before trauma and during trauma and after trauma, and can see the actual impact and what part of the brain trauma impacts and what happens afterwards. And you can see how the amygdala is affected, how that sort of more reptilian or limbic system is impacted, all of the different things that happen. So our brain is designed to protect us from danger, right? We have this response when we perceive threats. So we'll get into that a little bit more, but the fight flight, which now is 6 Fs, but the fight or flight has expanded, but the basic survival instinct is activated, and the brain sends signals to the body to prepare us for that. We've got cortisol and other adrenaline and things happening to prepare us to get our muscles stronger and blood flowing, and all of these things happening so that we're best able to protect ourselves. But then once that danger's over, our brains return to a relaxation state, and then we can go about our day, right? And we can experience joy and pleasure and interact with other people, and you're not in that high alert all the time. But when you've experienced trauma, especially repeated trauma, the brain no longer is able to, or is impacted in a way that is less able to distinguish between when you're in danger and when you're not. So that threat detection and interpretation has changed. So when we've experienced trauma, we may be thinking that we're in danger all the time or a good deal of the time, even if we're not. So those hormones are pumping, that relaxation state's not happening. That prefrontal cortex where all of our thinking and judgment and decision making, all those important pieces happen that allow us to process information, make decisions, that's impacted. So our self-access, which is the self-sensing system, our sense of who we are, even that's impacted. So you can imagine how much trauma is impacting us just by the changes it's making to the brain, the physical changes that it's making to the brain. And then it not only can change our own brain, but because of intergenerational trauma and epigenetics, it can impact us up to 3 generations. So, your great grandmother may have experienced trauma, and that changed the way the DNA expresses itself. That gets passed down to that next generation and the next generation and even a generation after that. So trauma can it doesn't change your DNA, but it can change the way that those genes are expressed. So you may be more susceptible to stress. You may be at a more heightened level of being more likely to sense danger sooner. You might be less able to return to that relaxation state. So these things can impact us even if the trauma didn't happen directly to us. And then if we have this epigenetic historical trauma and then our own personal trauma, that's kind of just layering on top of that impact. So if you've ever wondered, like, why does this event affect this person in this way and another person completely differently? Like one person experiences the exact same thing and is really traumatized, and another person, exact same event, seems to be fine, might be like a little bit upset or, wow, that was rough, and then kind of brushes it off and moves along. Why do we respond so differently to the same event? Or could even be the same person could respond to a similar event different ways at different times in our life, right? So I'm going to look at kind of why that happens. So there's this thing called the stress vulnerability model that explains a little bit of that. So all of us can be impacted by stress. Even if you're the most resilient, hopeful person in the world, you can still be impacted by stress. But some of us are more impacted than others. And it could be because of some of those things we talked about, right? Epigenetics, our history, our experiences with trauma in the past, how that sort of changed our brain moving forward, all of those things. It could be that there are just different factors and causes that place certain people at a higher risk for developing symptoms when they are exposed to a traumatic event. So, or a stressful event. So the stress vulnerability model is kind of a framework. It looks at like what are the biological, the environmental, all of those different factors that could impact the onset of PTSD or another kind of mental health issue. And why is it important to know that? Well, you think about what information or what kind of skills, what kind of care or treatment somebody might need to help them to be successful in recovery. You kind of need to know what their vulnerability is to stress, how an event might affect them, what kind of support they might need to recover from that. What do they need to create resiliency from that? That can be different based on their stress vulnerability. Some people need more than others, right? It's equal is not always fair, right? So the stress vulnerability model is based on the concept of psychobiological vulnerability. If there's a predisposition, then related to that stress, you're more likely to have an impact from that stress. Just like if you have a predisposition for heart disease or allergies or diabetes, then you're more likely to develop those illnesses than someone who doesn't have that predisposition. It doesn't mean you will, and it doesn't mean someone who doesn't have those predispositions won't, but it just means you're more likely to if you are already predisposed for that. So you kind of already has this vulnerability, and then you're in an environment that doesn't provide much comfort, doesn't provide the support that you need. You didn't have the opportunity to learn the skills that you needed. All of these kind of things just increase your risk factors. So experiencing trauma, not having coping skills, being exposed to substance use, especially earlier in life, all these kind of things just are increasing those risk factors. And then trauma in childhood, right? So the younger we are, we experience these adverse childhood experiences. What does that look like for us in childhood? But then what does that look like as we're going into adulthood? And how does that affect us long term? I think most people think, well, yeah, that probably does affect our mental health and our emotional well-being. But what it took, this study that was done by Kaiser and the CDC to realize was that it really affects our physical health and well-being as well in very significant ways. So the ACE study just used a very simple scoring method, just 10 questions. Each question counted for 1 point. If you had experienced this in childhood, then that was worth 1 point. If you hadn't, then that was worth 0. So you could score from 0 to 10. And what they found was that people who had scored higher on the ACEs were more likely to experience these physical health complications or issues later in life as adults. So, these experiences have serious health consequences. Trauma, adverse childhood experiences, traumatic experiences in childhood. This is a public health crisis. It is creating much higher rates of eating disorders, heart disease, pulmonary disease, liver disease, cancer, all of these things, a much lower life expectancy for people who have higher ACE scores. And it was as low as 4. If your ACE score was 4 or higher, you tend to have more likely to have these long-term kind of chronic health conditions than if your score was lower than 4. Is anyone surprised by that? So what did we learn about this? That study was quite some time ago. So we've been looking at this. We're finding that 1 in 6 adults have experienced the 4 or more adult ACEs, which we've already talked about. 4 or more is higher likelihood of those chronic, severe health conditions, right? So 1 in 6 of us are in that category. 5 of the top 10 leading causes of death are correlated or associated with adverse childhood experiences. 5 out of 10, that's half. Half of the leading causes of death can be related back to, in some way, adverse childhood experiences. And just preventing ACEs could reduce the number of adults with depression by 44%. And depression is one of the most common mental health conditions, right? So there's other ways that just thinking about if we could prevent adverse childhood experiences, how would that impact our health as adults? If we could prevent those experiences in childhood, we could decrease depression, COPD, asthma, kidney disease, stroke, heart disease, cancer, diabetes, all of these different things. Um, Smoking, heavy drinking, unemployment, not having health insurance, like all of these things could be decreased if we could just decrease or eliminate these adverse childhood experiences. These experiences in childhood are so impactful long into adulthood. So I think we kind of have an idea, right? Like trauma is impacting us in very significant, very real ways. And these ways are not only impacting us as individuals, but they're impacting us as communities. They're very expensive public, health impact as far as, they're costly to treat, and they, lead to lots of undesirable kind of community situations that we are all working to change, right? So if we can address these things with prevention, then we can, we can eliminate the suffering and the distress, but also we can decrease the cost of caring for folks. What are trauma-related symptoms of behavior? How does it come out, right? How do you see it? Like, how do you know? Like, it can come across in many, many different ways. So when you think about like, oh, someone has been traumatized, how I know? Well, one, sometimes you don't. That's why we want to screen for it. We'll talk about that in a minute. But we see it, right? We see it when we're serving people. Sometimes we see it with anger. Sometimes, people are yelling and screaming and upset about things that we are thinking like, oh my gosh, why are they so upset about that? That seems so small. But the reaction is not necessarily to the thing that's happening in that moment, but it's a trauma response to the feeling of not being in control. It's sort of the brain is remembering the experience of the trauma, and that is coming out in that moment. So thinking about like how are these behaviors, how is this coming across not only in the people we serve, but in staff, right? In the physical response, right? You can see people shaking or shrinking. Yeah. Okay, so we're going to talk about the 6Fs too. So we talked about the fight or flight. We're all familiar with that, and some of you may have also heard of freeze. And the more we learn about the brain, the more we know that there's different ways of responding to trauma. So we're up to 6 now. There'll probably be more in the future. I don't know, but I thought it was interesting to look at all of these different ways that our brain and our nervous system might respond to trauma. So the one that we're most familiar with, right? That fight. So you might see people coming in, they're angry, they're demanding, are you late for my appointment? I need to be seen right now, or, I need this medication, or, could come out in that kind of way. Could come out in, swearing and calling names and, all of those kinds of things, making threats and those kind of things. Flight can come out as anxiety, fidgeting, over worrying, avoidance, right? Working too much to try to avoid things at home, or, substance use to try to avoid the feelings, or, you can't get a hold of people. They never come to their appointments, right? They are, fleeing, freeze. They're just, paralyzed and, spacing out, losing time, just confused, brain fog, numb, maybe indecisive, not able to make decisions, kind of disassociating, and just, procrastination. Yeah. Fawning or friending, sometimes it's called, was just kind of this people pleasing, right? Like just if I just keep everyone happy, then I'll be safe, right? So I'm not going to rock the boat. I don't want to upset anyone. I'm just going to, I don't have my own opinion. I'm just going to, keep everybody happy and make sure that nobody's upset. This person might be really easy to exploit, right? They might be really afraid that they're not going to fit in. So they might be, doing those kinds of behaviors. Flooding, just kind of being just overwhelmed with emotions, all kinds of emotions kind of happening all at once. Really hard to regulate those emotions. You might be sort of anger and crying all at once, like all those kinds of things, and hard to regulate. Fatigue or flop can be just like the threat is just exhausting, right? I just can't deal with it. It's exhausting. These are folks who might just sleep a lot, right? I'm just gonna be numb, or I need to disassociate. Sleeping might be a coping strategy. Do y'all see some of these things in yourselves or in folks you work with or serve? It's kind of like, oh yeah, these are, yeah, yeah, some ways of responding to those threats. And again, if we go back to how trauma changes the brain, now the brain can't tell the difference as well between safe and not safe. And my brain thinks I'm in danger all the time. What seems like a really helpful response when I'm in danger now is probably not so helpful of a response because I'm not really in danger, but I think I am. So I'm responding in a way that's probably not very productive, right? But it's not intentional. It is a survival instinct. So these things can come across in like all of the different ways, right? This is just a very short list. It could be pages and pages long. It could be, disassociating, which please don't pathologize disassociation. We all do that all the time. If you've ever, driven a familiar route and been like, how did I get here? Because you disassociated on the way. It was familiar to you. We disassociate, frequently, but disassociating to kind of remove ourselves from that painful experience. Having a flashback where your brain is reliving that experience as if it's happening in the moment. Having nightmares or night terrors. That hypervigilance is a result of your brain not knowing that it's safe, right? So you're alert because your brain thinks you're in danger. If you think you're in danger, you're probably afraid. You feel terrorized. That if you feel like that all the time, probably feels like anxiety, right? So anxiety, distorted cognitions, like I can't tell if something's safe or not safe. How do I trust myself? How do I trust my own perception of things? Because my brain is telling me it's not safe, but everyone's telling me it is. Nothing bad happened. I guess it was safe. I guess my brain is wrong, right? Like that's really hard to kind of reconcile with yourself, right? So yeah, those kind of cognitive difficulties, difficulty with concentrating and focusing. How are you going to focus when your brain is taking in, all kinds of information and has difficulty separating out, what to take in, what not to take in, that ability to separate out important versus non-important information, has been altered. So it's going to be hard to focus, hard to concentrate. And if you're not sleeping well, everything else is harder. That numbness, survival skill to try to block out those emotions, depression, substance use. Again, I think substance use is a symptom of trauma. Self-injury, same thing. Eating problems, poor judgment, that continued cycle of, being in situations where you're likely to be harmed again. Again, your brain can't tell the difference if you're safe or not. So if everything feels unsafe, you don't have that ability to recognize when you're in danger. Any thoughts about any of this so far? Questions or anything? Okay. Making sense. Okay. So how do we implement trauma-informed care? I think first of all, we want to really understand that trauma is so widespread that we just want to assume that everyone we're interacting with has experienced trauma and just come from that universal approach, right? Just kind of universal precautions. I'm just going to assume that everyone I'm interacting with has got some trauma talking, and that's what's happening, and that they may be impacted by trauma, and I'm going to respond as if that's what's going on. And knowing that has a significant impact on health and well-being. And that trauma-informed care is a really important step to addressing and responding to that widespread need. So what are some strategies for how to implement that? We want to talk about okay, I realize it's prevalent, and I recognize, the ways that it can impact people. And we just barely touched the tip of how it can impact people. We could talk about this for days and days, right? How it can impact people. This is just such a short overview. But now that we have, some idea of that, what do we do? What do we do with that information? So how do we respond? How do we put that into practice? So one, we want to really respond to trauma from a foundation of trauma-informed values, really built on policies that support trauma-informed care. We want to create environments that are comfortable, that are safe, that are calming, and that are empowering to the people we serve, that focus on their strengths. What's strong, not what's wrong. It's what we say at RI, right? So really looking for how do we help them to increase their quality of life and move forward. We want to routinely screen for trauma. So if that's not something that's already built into your organization, I think that's probably a good place to start, is looking at how do we routinely screen every single person who comes in to see, what is going on, have they experienced trauma, what kind of trauma, how does that trauma impact them, what do they think about how that trauma is impacting them currently, are they currently experiencing trauma right now? Okay. Yeah. And we want to ensure that staff are trained to respond with interventions that are trauma informed and person driven. We talked about, right, how trauma, one of the first things that happens is you lose that sense of control. And so the last thing we want to do is re-traumatize people by having them in situations where we rob them of their sense of control. So we want them to come into care being, really reminded that they're in charge. It's their care, and they're the ones that are directing that. Want to, create safe and healing environments and prevent that re-traumatization. So that's a lot. How do we do all that? Right? So again, the universal precautions, we're going to act like everyone we encounter has experienced trauma, and that could be impacting them, and not just the people we serve, but our coworkers, our colleagues, the other agencies we're working with, the visitors, people in the community. That could be, what's impacting any particular interaction at any time. And we're going to practice really good self-care. Because what's not helpful is if we have our trauma talking to their trauma, right? Like if if we're not regulated ourselves and when we just have two trauma talking to each other, it's just probably going to escalate the situation. So being able to practice really good self-care, regulate our own emotions, get our own amygdala regulated, and make sure that we are taking care of our own self, healing our own trauma, and so that we can offer a place of calm for people to, we can invite people into, um, you know, using a very non-judgmental approach, creating that healing environment. Yeah, we need to be ourselves. Consider and address pervasive crises, right? Sometimes people are just in crisis all the time. And sometimes that's because there's lots of reasons for that. Sometimes it's because of, that's um, a lot of historical, cultural, different reasons why people don't have access to things. All of those things can create that. But also, what's familiar feels comfortable. And so our brains are wired towards familiar is safer. And so we unconsciously can sort of create situations that feel familiar, even if they're not healthy. So trying to address and prevent this kind of pervasive crisis so that we can find a sense of safety that will allow a person to start that journey towards healing. It's very difficult to begin healing if you're in the middle of trauma, right? So how do we create trauma-informed environments? I would encourage each of you just to go back to your organizations or your offices or wherever you work and just look around like you've never been there before and just see what it looks like. If you were kind of walking in for the first time, what are the postings on the walls? Are there signs that say don't do this, know that? Are there a lot of rules or things like that? Are there things that are welcoming for different cultures? Does it, is it something that would be warm and welcoming for people of different sexual orientations, genders, religions, all of those different factors? Is it accessible to people of different abilities? Is it what are the colors that you are using? What are the things on the walls and all of those things? Does it create a sense of calm? Does it create a sense of you're welcome here? Are there kind of plastic? I know with COVID there might be plastic barriers, but are there sort of barriers between staff and people that we're serving that might create a sense of like distance or those kinds of things that might feel unwelcoming? Just kind of looking around your environment to see, is this a place that I would want to come or want my loved one to come? Do we have comfort kits? Are we training every single person on our staff in trauma-informed care, including and especially our front desk people? These are the folks that are the foundation of every service, right? So these are the people that answer the phone, that talk to people at the first voice they hear. They greet people when they come in the door. They're the first interaction people have. So a comfort kit can be something that you have, whether it's a therapist or peer support specialist or the front desk person has something that if they're noticing that someone appears to be in distress, or just seems uncomfortable, that they can offer them something, whether it's a glass of water or a cup of tea or a stress ball to squeeze, or some lavender to smell, or some soft music to play, or some adult coloring sheets, or things that might be soothing. People's nervous systems don't always work the same though, so sometimes people need soft, soothing, comforting things. Like my nervous system needs comfort, right? Like I want a big fluffy pillow and a quiet room and nice soft music and something that smells good. Other people's nervous systems, they need input, right? So you might see this, especially if you're working with young people. They want hot, spicy chips, and they want to go walk really fast or run. These are probably your folks that really enjoy roller coasters and amusement parks and bungee jumping and these kinds of things. But so you have kind of those things available too, kind of the spicy foods and the calm apps or those things. Is there a place that you can go walk with someone who seems distressed? But just kind of having that mindset and that awareness, like, hey, this person seems to be distressed. Can I offer them different things that might be helpful to them? And trying to get to know the people that we're interacting with enough to know what might be soothing for them. If you haven't, or if you're not already screening for trauma, there are some ideas for some screening tools. Feel free to take a look at those if you'd like. Yeah, really cold or really sour? Absolutely. Yeah, something really cold on the temples is really nice, right? Can help snap someone out of a really difficult moment. There's all kinds of trauma-informed interventions. I listed a few here, but I would say the most important thing is just realizing that trauma is usually stored in kind of not the verbal part of the brain. Those memories tend to, strong emotion tend to be stored in the amygdala and on the right side of the brain. So it's not always easily accessible verbally. So being able to do things that are nonverbal. So, art projects and music and, things that are creative. Those are great. New activities. Really making sure that we are person driven foremost, right? People are in charge. Things that regulate the nervous system. So anything that incorporates kind of repetitive rhythmic movement is going to help regulate the amygdala. And if you can get the amygdala regulated, then you can start to free up that prefrontal cortex. So then you can move into being able to have more judgment, reasoning, decision making, those kind of skills. Until you get that amygdala regulated, those skills are just not accessible. So when we get really frustrated, right, is when we are trying to reason with someone who is, in the middle of that moment where they're dysregulated and we're really frustrated because they're not logical. They literally cannot be. Because they can't access that part of the brain at that moment. So if we can help someone regulate first, then they can, and then we can move forward. And that's true for all of us. Our brains work the same way. So if we're not regulated, we're not going to be able to access that part of our brain either. So being able to incorporate those repetitive rhythmic movements, that's why, tapping, EFT, right? This is like why I think adult coloring has become so popular, right? It's repetitive, it's rhythmic. EMDR is repetitive and rhythmic. Walking, swimming, jumping on a trampoline, all of these kinds of things can be really helpful. Trauma-focused cognitive behavioral therapy can be really helpful. There's stress reduction and stress inoculation techniques. So what do we talk about? Stress vulnerability, right? Increase that. So helping to reduce that stress. Training staff on verbal de-escalation, right? We want to decrease the chances of moving into any kind of seclusion or restraint kind of response. So if we can de-escalate verbally, help people regulate, then we can have a more therapeutic interaction. Yeah, you guys are sharing some great ideas. Same kind of thing for children, but there are some different trauma-informed interventions available. So one, I would start with regulating the nervous system, anything that's repetitive and rhythmic again. There's some different things, alternatives for families is a cognitive behavioral therapy, culturally modified trauma. Really important to look at what's culturally appropriate for folks. Integrative treatment of complex trauma for adolescents. There's the SMART, just safety mentoring, advocacy, recovery, and treatment, or the sanctuary model. So all kinds of different evidence-based treatments and interventions out there. So really looking at, what works for you, what works for your organization, what can you train your staff on to make sure they have those tools available. Any questions? Okay, we're at the 4th R. So resisting re-traumatization. So we realize it's prevalent. We recognize the effect. We're responding in trauma-informed ways. We're, creating calm, comforting, welcoming, nurturing places, right? We are training staff. We are making sure that people know how to recognize trauma and how to respond to that. We want to assess our organization. We want to, not sort of rely on anecdotal evidence. Are we trauma informed? I think so. Can we kind of do a formal assessment and get data and really look and see, are we doing what we think we're doing, or where are we at now, so that we can figure out what we need to do to get to where we want to be, and then periodically reassess to see how we're doing for making progress. Are we where we want to be? Follow the trauma-informed principles. Hire and train trauma-informed staff, right? We're not going to have a trauma-informed organization without trauma-informed staff. And one way you can do that is to use trauma-informed interview guides. So if you're asking questions about trauma and what staff think about trauma and how people respond to trauma in the interview guide, you're much more likely to bring on folks who are going to share your approach and values around trauma-informed care. And if you're not, yes, rocking chairs are a great idea for the environment. Repetitive and rhythmic, right? So what are the principles? The trauma-informed principles. Safety first and foremost, right? We have to have safety. We cannot heal from trauma in a place where we don't feel safe. So creating safety is really important. We have to be able to protect people from danger, emotional, physical, and psychological, as well as kind of managing crisis. So doing those things, being trustworthy and transparent. I mean, that really falls right into creating safety, right? People are not going to feel safe if they feel like we're not trustworthy. So creating that trustworthiness, it can be really simple things too that we might not think about. So things like if we say we're going to be somewhere at a certain time, that we are there at that time. If we tell someone that we're going to send a referral, that we send the referral. If we say that lunch is at this time, that lunch is at that time. That if we have to make changes to anything, that we tell people, as soon as we possibly can, and offer information as to why. Creating predictability is really important because it creates that sense of security and safety. Because what did we talk about with trauma? The first thing that happens is it shakes our belief in predictability, right? So things that feel unpredictable and unstable feel unsafe. So if you're going to change your group times and you're going to, change your appointment times, not tell anybody, your trustworthiness is out the door. One of the things that's the hardest for us, I think, in this industry with creating trustworthiness is turnover, right? So a person who's coming in for care, and then I've had 7 case managers in, the last 2 years. That's really hard for us to create that trustworthiness. So as much as we possibly can, trying to create trustworthiness by creating predictability. And collaboration and mutuality, right? That person's in the driver's seat. We want to make sure that we're working with the person, that we're working together, we're establishing goals together, we're establishing what interventions we're going to be working on together. All of those things are done in partnership. Empowerment, you can, see so many examples of where this can really be important and come into place. But especially if you think about those 6 F's and you think about the fawning and you think about the person who's like, oh no, whatever you want is fine with me. And it would be so easy just to go with that, right? But that's just going to reinforce that trauma response. So taking the time to really find out what does that person actually want and help them to get what they actually want, and spending the time to really make sure that they know and understand themselves and what they want and are able to ask for that. Recognizing their own voice, their own choices. Yeah. Peer support, having people with lived experience partnering with people so that there's that mutuality and self-help, that people can know that there's hope, that people with the same types of experiences have recovered, that recovery is expected, that not only is it possible, but it's expected, that other people have had the same types of experiences and have recovered, and that someone with a lived experience can relate to what they're going through. Focusing on post-traumatic growth and resilience, looking at strengths, looking at how are we going to use those strengths to work through these challenges, and really looking at functional strengths, not just like, oh, you like to color, that's great, but how is that strength going to be used to help you achieve your goal? Inclusiveness and shared purpose, that, this is really an inclusive process. Like how are we coming together for a shared purpose, a shared goal, working together on that? Where, who can we involve? Community partners, natural supports, are there family, are there friends, are there, other people that are important to them that can be involved? And never forgetting about the cultural, historical, and gender issues that might be impacting that person's well-being, their health, and the way that they seek and respond to care. Here's just one example of a trauma-informed organizational assessment. There's lots of different ones out there, but this is one specifically for kids, and if you're working with kids and families. One way to assess your own organization and where you're at is to do something like this, where you're doing an organizational assessment that looks at different areas. Are you screening for trauma? Are you doing assessment, care planning, and treatment that's trauma informed? Is it collaborative? All of those things. What's the workforce development? Are we hiring and training people who are trauma informed? Are we working on strengthening resilience and protective factors? Talked about all the risk factors. Are we looking at protective factors, and are we looking at building those up? Are we creating new experiences? Are we creating safety? Are we creating wins? Are we addressing, if we're working with kids, are we addressing the trauma of the folks that are taking care of those kids? Continuity of care and cross-system collaboration. If people are moving from one agency to another, are they going to experience trauma-informed care at every agency they go to? Or is it going to be traumatizing in one agency and then, having to move to another agency to find something that is more healing? addressing, minimizing, and treating that secondary traumatic response and stress. So taking care of our workforce, the secondary trauma of hearing about the trauma of working with people who've experienced trauma, being exposed to that trauma on a daily basis. Partnering with the people that we serve, that collaboration and mutuality. Are we doing that? Or do we, write up care plans or treatment plans in our office and tell them what we're going to do? Or do we do it together? Do we do it together and then put it away and do what we want? Are we really actually partnering with people throughout the whole process? And addressing the intersections of culture, race, and trauma. Are we doing that in a strategic and effective way? So using some type of tool to strategically assess your organization to see where you're at and see what areas you would like to improve, and sort of pick an area and start with that. So in conclusion, trauma-informed approach begin with the very first contact we have with someone. That first phone call, that first person they see when they walk through the door. So it requires every single person in the organization to be on board with a trauma-informed approach, whether that's the person at a call center, the receptionist, the person doing the intake, your supervisors, your administrators, your board members, everyone, to recognize that person's experience of trauma can greatly experience their engagement with services, with staff, with your program guidelines, with practices, and with their care overall, and that it can impact everyone. All right. Any questions? Sue Ann, I will hand it back over to you.
All right, thank you so much. That was so informative. I know it was a lot. We packed a lot into just over an hour. I'm gonna invite you to unmute yourself if you have questions. I had a couple of things I noticed in the chat that I just wanted to point out, and there was kind of a theme Dr. Weldon threw out about giving clients choices, options, permission, how this experience of trauma is rooted in feeling unsafe, feeling out of control. And several great examples were put in the chat of giving clients options, asking permission before doing something. Somebody said the client gets the big comfy chair and I get the smaller and shorter one, which I thought was clever, kind of putting that control back in the seat of the person seeking assistance. So there was lots of great stuff, and thanks to all of you for all the amazing things that you put in the chat. We had a couple of questions. One was around, I thought this was kind of interesting, and wonder your thoughts. Somebody in the chat wondered about specifically the flight response. And then I personally also thought, when you were talking about a person whose amygdala is all active and you're overstimulated, not being able to concentrate, they wondered if those kind of responses could often be mislabeled as ADHD. Thought that was an interesting kind of comment.
Absolutely. That's what I didn't say when I said sometimes these could be misdiagnosed, but it's really trauma. That's what I was thinking specifically for ADHD. But it could be misdiagnosed as other things as well. But yeah, I think if we aren't looking at trauma first, that we're probably much more likely to misdiagnose with all kinds of things. But ADHD is the thing that comes to mind first. Yeah. I
guess that's why it's really critical what you've said a couple different times. Like, let's just assume if, 70, maybe even 80% of folks have had at least one ACE item on the ACE score. And for those of you that have never seen the ACEs, you'll be getting the PowerPoint with links to that as well. And then we know that that number jumps to 90% for those seeking behavioral health treatment. And so this idea of universal precautions, like just assume that everybody coming in has that experience and doing a proper screening for trauma, I think can help with that differential diagnosis so that so you minimize the misdiagnosis as well. Let's see, what else do we have? Did anybody want to unmute and ask any questions of Dr. Weldon? Somebody said, please dive a little deeper into the fawning response. I think you also called it friending, which I have never heard, and I liked that. That's easier to remember what that is.
Yeah, the fawning, friending. So, you know, if you have experienced an environment where you are unsafe and your survival strategy is to keep everyone happy, right? Because that will increase the likelihood of you being safe. Then, you know, this sort of fawning or friending response can develop. And so you might be sort of the yes person, or, you know, kind of like whatever you want, not being able to make a decision. You know, sort of if you think of that, you know, kind of people pleasing, you know, someone who really is just, you know, wanting to make sure that other people are happy at their own expense, not able to really set healthy boundaries. They could be really easily exploited, you know, that way, because they're, you know, kind of just like, you know, I just needed this person to be happy, so I just did whatever they wanted. It could be someone who is going to have sex with someone who doesn't really want to have sex with that person, but they just want to keep that person happy. And so they're going to do this just to make sure that person doesn't get angry, because it feels dangerous to stand up for themselves or to express an opinion. You know, this could come out at work, your coworker who is always like, whatever you guys want to do, right? It's fine with me. Who never, you know, kind of wants to say where they want to go to lunch, even, or, you know, you're working on a group project and they're like, whatever the group wants, right? It can come out in those. That could be a trauma response, and we might just think it's like, oh, this person's so easygoing, you know, it's great. They're so easy to get along with. They just do whatever, but it could be a trauma response. So this something to think about, that, you know, it's nice to stop and, you know, sometimes just say, I really want to know what you think. I really want to know what your opinion is, and give people a safe space to express that, to let people know there is no wrong answer. Like, anything you say is okay. You know, giving people, you know, permission, even though, you know, we don't really need permission. We can give ourselves that permission, but sometimes people think that they need that, or feel like they need that. So giving people, you know, that, you know, verbal okay. Telling people at the beginning of an assessment that you don't have to answer any question that makes you feel uncomfortable. Sometimes people want to please you, so they will tell you what they think you want to hear instead of what's really going on. And so, you know, if we respond to something with, oh, that's great, then they might tell you more of that next time, even if that's not really what's happening. So, you know, just being aware of those things. Yeah.
Thank you. We do have another question. If trauma often mimics ADHD symptoms, what's the best way to tease out the more accurate diagnosis? would that be to give the ACE, or you have other suggestions? I didn't want to answer for you.
That's a really good question. I think screening for trauma first, right? To make sure that we know whether trauma is a factor or not, and probably taking more time to fully assess. Sometimes we tend to jump to a diagnosis pretty quickly, and not rule out sort of other things first, including physical or medical things that could be going on. You know, some things that are really interesting about integrated care is you can give the exact same scenario to medical providers and behavioral health providers, and you know, your behavioral health providers will be like, you know, this is autism, and your, you know, medical providers will be going like, they've been exposed to lead, and you know, this is what's happening. So just taking some time to, you know, rule out other things and make sure we've considered all the factors.
Do you ever ask a person in session, you know, I have a tool that can, like the ACE tool, and ask if they'd be willing to do that as a way to kind of get right to the point? Or do you not start with that usually, but start instead with like a complete biopsychosocial?
I think adding the ACE to the complete biopsychosocial and screening routinely would be great, but I think it's also okay to present that to someone like, you know, would you be interested in completing this assessment to see if maybe these things that might have happened when you were younger are impacting, you know, your current.
Yeah.
And again, I think it's just so important to ask for permission before, you know.
Absolutely. Nicole has posted a question a couple of times, so I want to make sure we get to it. She asks, how do we ensure that we are not enabling while also making sure that we're being trauma informed? I think that's a good one.
That is a good question. What do you mean by enabling? I think that's always an interesting question from folks. So I guess kind of looking at ourselves and trying to think of what are we trying to accomplish versus what is the person trying to accomplish? Do we have a goal for them that's maybe different than their goal for themselves? And kind of looking at maybe where that's coming from or what that's about. Sometimes we kind of think like, oh, this person's, you know, has this goal to do this, but I really think they need to stop using or leave this relationship or, you know, whatever it is. And so then we feel like if they're not making progress to the goal that we have in mind for them, that maybe we're not doing enough. So what I kind of remind myself and the folks that I work with, the staff that I supervise, something that I learned from Matt Pierce is that what we're responsible for is creating opportunities. And then what people do with those opportunities is up to them. And so I'm not responsible for the outcome of that. So if I'm creating an opportunity for someone to experience safety, to experience something healthy and new, to experience an opportunity for healing, to have access to resources they didn't have before, to have access to new tools, new coping skills, to have the opportunity to create new connections and new relationships, then that's my job. And then I've done my job. So I'm creating that opportunity and I'm being consistent with creating that opportunity. Absolutely. Thank you. Then that's what I can do. And then it's up to them.
Great. Thank you.
So, I don't know if that really answered the question.
I see a lot of thanks in the chat. I'll give everybody just one last chance here to either unmute and ask a question before we break, or to put it in the chat. Somebody did ask, do you do any trainings for children? I would recommend that you, when you get the slide deck, one of the last slides has information on how to contact CARE TA directly. And that's a question for them. They might have somebody that's a specialist. We can certainly do that if CARE TA wants to bring us back to do something specific for children. We'd be happy to do. Oh, there it is. Thank you for bringing that back up. So this is how to request technical assistance from CARE TA. The link is in there. So if you want additional information, you're thinking that a youth specific trauma training would be good. This is all stuff that you can request of the TA Center and or suggest as topics for future training events. So that would be really very helpful. Thank you everybody for your time and joining us this afternoon. Thank you, Dr. Monica Weldon, for all your expertise. I hope that everybody here learn something you can take back to your practice. As I said, you will be getting a copy of the recording, copy of the slides, which has several links in it. And we created a little one-page cheat sheet for you based on Dr. Weldon's presentation that you'll be receiving as well. Just a one-pager, easy reference guide. So I thank you all and have a good rest of your day. Thank you. Bye-bye.